Good Monday evening to everyone and welcome. Happy fall. Thank you for joining us to start your week. My name is Ryan Googe and I am the Executive Director of the Partnership to Advance Cardiovascular Health, which you'll hear us call PATCH for short. First of all, I want to thank Amgen for sponsoring tonight's webinar. PATCH is a coalition of a number of doctor, nurse, and patient organizations that work for better for people living with heart disease. You can see on this slide many organizations that we collaborate with. PATCH's mission is about helping people. We want to make sure that anyone who has had a heart attack or stroke, or anyone who is at risk for having a heart attack or stroke, can get the care they need to live long, productive lives. I love my job for a lot of reasons, but principal among them is that I have the opportunity to work with a lot of amazing patients who have persevered through trying times. And I also have the opportunity to meet and work with some of the leading lights in heart medicine. People like our speaker tonight, Dr. Seth Baum. Clinicians like Dr. Baum are busy and keeping up with their practices, but they also take time from their busy schedules to advocate for better medicine and for better patient care. How do you do life once you've had a serious event like a heart attack or stroke? How do you manage risk if you know you could have a heart attack or stroke? Is cardiovascular disease preventable? What are the best practices for keeping your heart healthy? Though we may be distanced by a computer screen, we hope to answer these questions and some of your own as well in the discussion, a heart-to-heart, if you will, about our most important organ, our hearts. Tonight we'll have two conversations. Our first heart-to-heart will be with Dr. Seth Baum. Dr. Baum is a distinguished cardiologist who lives and practices in South Florida. He's a fellow of the American College of Cardiology, the American Heart Association, the American College of Preventive Medicine, the National Lipid Association, and the American Society for Preventive Cardiology. He's written a couple of books. He speaks both nationally and internationally on cardiovascular prevention. And I should also say that he's a steadfast advocate for patients and a good friend to our organization, the Partnership to Advance Cardiovascular Health. Joining Dr. Baum will be two fellow Floridians who are currently living with heart disease, Annie DeVelasco and Ken Karlson. Today, Annie and Ken are active patient advocates who raise awareness of heart disease with women heart and men at hearts. Everyone watching us live this evening should feel free to ask questions in the Q&A box you'll see just below the feed, and we'll do our best to incorporate the questions into our discussions. And with that, I'd love to invite Dr. Baum to the screen. Hi, Dr. Baum.
Right.
How are
you? Good. How are you?
Good. Thank you. Thanks for taking some time to talk tonight about heart disease with us. You know, as you know, we've organized this webinar as a source of information for people who have either had a heart attack or stroke or know they're at risk for one. And so the question that I want to start with is about the different classifications of prevention. So folks who are watching have probably heard of primary prevention and secondary prevention, but I'm the kind of guy who likes to ask the questions no one else in class will ask. So my first question to you is, what is primary prevention and what is secondary prevention in heart disease?
So there's actually also primordial prevention. So there's primordial, primary, and secondary. And in some classification systems, there's actually tertiary as well. But let's just stick with primordial, primary, and secondary. So primordial prevention is a prevention scheme in which we avoid developing cardiovascular risk factors in the first place. So for example, high cholesterol is a cardiovascular risk, right? Primordial prevention would attempt to diminish the likelihood that one would develop high cholesterol, perhaps by maintaining optimal weight, eating a healthful diet, exercising, not smoking, never smoking, right? So those are elements of primordial prevention. Primary prevention is treating a cardiovascular risk such as high cholesterol with diet and exercise, yeah, but also with medication when needed, treating blood pressure when it's high, treating overweight appropriately. So, attempting to modify cardiovascular risk factors so that we never develop um, manifest heart disease. We never develop a heart attack or a stroke or the need for a stent or bypass surgery. Secondary prevention is what we do when we've already developed manifest heart disease. So somebody's had a stent or a bypass or a stroke. And then we go on to do other risk factor modification, um, uh, which can be the same stuff, lowering cholesterol, but it would be all geared toward not having another heart attack, not having another stroke. So that's pretty much how we define these terms.
So, Dr. Baum, I'm curious, a lot of the folks that are watching tonight are probably in the primary secondary prevention, phase. So what's the major difference from a like a clinical point for these people? Like what are you how intense is the treatment between a patient that's trying to wean off, primary prevention versus secondary prevention?
Well, look, in theory, we should always be really pushing primary prevention, right? Primary prevention should be just as aggressive, in theory, I'm saying, as secondary prevention, because you never want somebody to go and have a heart attack or a stroke. In reality, though, it's hard to practice primary prevention because we have to treat so many people. Basically, we're looking at the entire nation and attempting to manage risk factors, as opposed to a much smaller subset, those individuals who have had events, excuse me, and managing them with risk factor modification. So we are much more aggressive in our guidelines, in our medical guidelines, and in our medical efforts to address secondary prevention. When we use lipid-lowering therapy, cholesterol medication, for example, our guidelines stipulate that we should be much more aggressive, use multiple medicines, attempt to get a much lower LDL cholesterol in those individuals who've already had an event. And the reason is that the higher the risk of an individual, basically the more bang for the buck, the better the more effective the risk reduction strategy will be. So if somebody's had a heart attack already, and let's say we took 100 people with heart attacks already, they're at very, very high risk for having another event. Therefore, if we treat them aggressively and lower their cholesterol, we're going to reduce the absolute number of events much more so than if we took 100 people in primary prevention and tried to reduce the risk of a heart attack in a similar fashion. So you just get a lot more out of it when you do secondary prevention. But in my view, sometimes by focusing so much on secondary prevention, we ignore the importance of primary prevention, because I think if we could stop everyone from ever having had a heart attack or a stroke in the first place, we would be a lot better off, obviously.
Spoken like a true preventive cardiologist, right?
Right.
So, Dr. Baum, I've talked to a lot of patients over the course of my career with Patch, and I'm always surprised by the number of folks who are relatively young. They never thought they'd have a heart attack or a stroke, and one day they're at their, daughter's softball game, and bam, they're in the hospital. And they always say, "This literally never crossed my mind that this could ever happen to me. I felt like I was in pretty good shape. I didn't eat that poorly. Just not something that I ever thought would happen." So what I'd like you to talk about a little bit is the genetic or the inherited component to heart disease. Because my impression is that people don't really consider heart disease as an inherited thing, or that there's some inherited component. So can you speak to family history and how important it is when you're considering or thinking about heart disease?
Yeah, it's immensely important, and often really underestimated by clinicians and patients alike. And part of that problem is that we have not identified single genes, or many, I shouldn't say. We have identified some, but we haven't identified many of the genes responsible for causing premature heart disease. But it is very, very important. It always goes into the calculation. If you're looking, when we look at patients and we try to assess their risk and determine, therefore, how aggressively to manage that risk, genetics is very important. There are some genetic tests that are currently available that look for what's called polygenic risk factors, which means multiple genes that conspire to cause a heightened risk of a vascular event. These tests are sort of young and new, and so we don't really have guidance on how to utilize them in clinical practice. But they're out there, and they will definitely improve over the next few years, I would predict. The premature heart attack, which is what you just described, is really frightening for a number of reasons. One of which is that some of these young people present with sudden death as their first manifestation of heart disease. So it's particularly scary and particularly disturbing, and you're getting people, sometimes in the prime of their lives with young families, and it can be a terrible event. So just it's important to sort of highlight that and make people aware that if they have risk factors and they're not that old, they still need to be very vigilant about those risk factors and see their physicians and get the appropriate care, take it seriously, and try to stave off heart disease. And we also have certain tests now that can assess early heart disease, early coronary artery disease, and with CAT scans of the coronary arteries, for example. And these are pretty widespread. They're pretty easy to access nowadays. So, and along those lines, I think it's also important for people to be their own advocates, because they're not always, they're not always in our guidelines, for one thing, and then they're not always recommended by physicians. But that doesn't mean that you can't access some of this stuff, and that it can potentially be of value to patients.
So I've actually got a couple questions here. You've opened up a box.
A can of worms.
Yeah, we hadn't originally thought of what we were going to talk about, but that's okay. We have a question from the audience about primordial prevention.
Oh my God, I should never have mentioned it.
I know. So the question is, do guidelines focus on primordial prevention? I only see primary prevention when I do research online.
Yeah, not really. Okay. And it's one of our deficits. And primordial prevention would also include things like limiting pollution. Okay. Because that's bad for people. Stress, reducing stress would be a primordial prevention technique. So meditating as a general principle. So so the problem is, as I've alluded to before, that we don't really focus on primary prevention that much, even because the swath of individuals that we would cover is so huge. Well, with primordial prevention, it's everyone. It's literally everyone. So that's part of the problem. It's hard enough at this point, unfortunately, to get people who require lipid-lowering therapy for secondary prevention. These are people who've had heart attacks and strokes. To get their LDLs to our current goals of less than 70, for example, fewer than 50% of these patients achieve that LDL. And this is our highest risk patient population. So, because of that, the medical focus has been really on the highest risk. You got to, manage the highest risk individuals rather than going after the lower risk individuals, which represent a much larger portion of society.
So let me actually another question in the box about LDL. So I'll just go ahead and throw this one to you too. And that is, what is considered optimal LDL? And I'm sure this is a question that almost every patient that's been to a cardiologist, struggles with their cardiologist with. What's your answer to that?
So we know that elevated LDL cholesterol is a genuine risk factor for cardiovascular disease, and what that means is it causes vascular disease, directly causes, not just associated with coronary artery disease and peripheral vascular and cerebral vascular disease, but actually causes the vascular disease. We also know that if we were to live in nature the way man had lived millennia ago, and the way young children would be without the influence of our Western world, we'd have LDL cholesterol levels in the 30 range. Um, so that's seems to be sort of optimal.
Mm.
So having said that, what that means is that anything higher than 30, or 40, or you can even go to 50, but let's say 30s, 40s, anything higher than that starts introducing some risk, because LDL causes vascular disease. So, it's not practical to get everyone's LDL down to that very low range. So instead, what our guidelines are pragmatic in many ways. And so we go after different tiers of risk with different levels of LDL as being considered optimal. So in our very low risk population, we may say an LDL under 100 or under 130 is okay. In our very high risk population in the United States, and that would be individuals who've had cardiovascular events and have comorbidities such as diabetes, high blood pressure, familial hypercholesterolemia, and a few other things, that less than 70 is optimal for an LDL. In Europe, that same patient who is at very high risk, we say less than 55 milligrams per deciliter is optimal, and even in some cases less than 40. So we drive LDL down to those goals according to the risk of the individual patient. Again, these are somewhat arbitrary cut points, and if this were a perfect world, we'd all have LDL levels in the 30 range or 40. And vascular disease would be very, very significantly curtailed if we had that.
So we're talking about managing risk ultimately here. So I want you to speak for a moment to the risk of having another event after having an initial one. And I think what I really want you to kind of zero in on here is for folks that have had an event of some sort, or what's the most important period for them to really hone in on their health after having an event? And do you have any, uh, any best practices for folks in that time period?
So again, we get into a little trouble when we start doing this, because once you say, well, this is the highest risk period, then you're sort of giving some freedom to those other periods. Just like in primary prevention, you're saying, they're at lower risk, so maybe we don't have to be as aggressive. So in the best of all possible worlds, we'd be worried forever if somebody has an event. But in reality, the greatest risk is early after that heart attack or after that stroke. And in the first year after the heart attack or the stroke, the risk is extremely high, 20 to 25 or even 30% in some studies, depending upon what you read, but certainly 20%. And that 20% risk can be a recurrent heart attack, the need for bypass surgery, the need for another stent, for example. So the risk is real and substantial. It's not like a little minor risk. So what should we do? Well, the moment somebody has an event, whether it's the requirement for a stent or for a bypass or a heart attack or an ischemic stroke, we should be incredibly aggressive at risk factor modification, including getting that LDL level down exceptionally low. I would drive it really. I mean, our guidelines, once again, say 70 here in the States, 55 or 40 in Europe. Uh, if you want to be extraordinarily careful, get it down under 40. Just do it, with your doctor. You're obviously monitoring for side effects from medications. But the reality is that we've shown that getting very, very low LDL cholesterol levels in and of itself is not inherently dangerous. In fact, it's only beneficial. We have not found a low point of LDL where there is danger, and that's getting under 25. Okay, well under 25. I would get that LDL down, make sure the blood pressure is good, make sure your diet is good, make sure you're maintaining optimal weight, make sure you're exercising, make sure stress reduction is being practiced. These are the things that need to be focused on. Again, the first year post-event is that highest risk period. But it's not like you walk out of that first year and you go, everything's great. I made it past the first year. There's
Right.
still very high risk.
So, another question that just came in the chat that I want to ask you about is, in so many across, preventative medicine, there are certain checkpoints in your life when you're supposed to get certain exams done. What age do you think you should get your LDL checked? Is what somebody asked.
No, that's a great question. So I think everybody should have an LDL check by the time they're 10 or 11, at least once. In patients who have children, in patients with familial hypercholesterolemia, when they have children, those children should be checked at the age of 2. So, and we're not doing that enough. We're not checking those babies, and we're not checking the kids at 10 or 11. And so it's a problem. But if you have that baseline, if you understand where a child is at 10 or 11, first of all, some of these kids actually need medication. But if not, at least you have a sense of where they are and whether you have to, be more concerned and be more attentive to diet and exercise. But then after that, I don't really necessarily follow the guidelines on this. I would check people when they're in the 18 to 21 range, let's say, assuming they were fine at 10 or 11, and then certainly every 3 to 5 years after that until they're 35 or 40, and then I would do it at least annually. That's my own bias.
Let me ask you about, you mentioned diet and exercise, and we haven't gotten this question yet here. We might in a minute, but we have in other heart-to-heart webinars. What's your opinion? I mean, there's lots of diets out there and fad diets, and there's, these things come and go. But what's your take on diet and exercise? Is there an optimal diet in your mind? Is there optimal kind of exercise in your mind for patients who are at risk for heart disease?
Well, with regard to exercise, there are really 3 components of exercise. Resistance training, which is weightlifting, aerobics, using large muscle groups for long periods of time. That's jogging, walking, going on elliptical, rowing, biking. And then there's stretching, flexibility training. And all of them are important. Flexibility, not necessarily from a cardiovascular standpoint, but from an overall health standpoint, is definitely important. The other 2, resistance and aerobic training, both have cardiovascular benefit. So I would say a good exercise regimen should incorporate all 3, but certainly a good cardiovascular exercise regimen, at least the aerobic training and resistance training. And I would say 5 days a week, at least 30 minutes a day. So that would be a reasonable and a good exercise program. Now, with regard to diet is a little trickier. Diet, our ability to do diet studies is very limited because every food has so many different components, even the fats. So if I'll give you an example, if we use olive oil as an example, and olive oil is like the quintessential healthful oil, right? um, we think of it as monounsaturated fat, oleic acid, but the reality is there's also polyunsaturated and some saturated fat in olive oil. So every fat, every source of fat has some of the quote unquote bad fats like saturated fat, and then even the bad fats like fat from animals, animal fat has some healthful fats like monounsaturated and polyunsaturated fat. So it makes it very challenging to determine, from diet studies, what's good and what's bad. However, having said that, certainly, emphasizing vegetables in a diet is good. Emphasizing fruit, as long as sugar is not an issue. In patients with diabetes, sometimes we limit fruit because fruit has sugar, and certain fruits are more sugary than other fruits. And then protein sources. So protein sources from beans can be a good source, but I mean, lean meats, chicken and fish, also a reasonable source. Emphasizing fatty fish like tuna and salmon and sardines and mackerel, good, because the omega-3 fatty acids are very healthful. It's important to manage portions because weight is I think one of the most important elements that's associated with diet. If you're eating a healthful diet but you're very overweight, that's not good. So maintaining optimal weight is very, very important. And the salt, the absence of salt, if in people with high blood pressure, I think that's a very important element of diet as well. So I would say, does that answer the question adequately,
Um,
Ryan, or should I go on?
no, I think so. No, that's good. That's good. Very helpful. A lot of folks who are watching Dr. Baum have probably had, well, hopefully they've had the opportunity for cardiac rehab or the option of cardiac rehab after having a heart event of some sort. So, and maybe they've taken advantage of it, maybe not. But can you walk folks through what happens at cardiac rehab and why it is important for recovery?
Okay, so in a sense, cardiac rehab does start, in hospital during an event or right following, a surgical procedure or a stent, um, where patients learn about risk factor modification. They learn about smoking cessation, management of blood pressure, management of lipids, and start a rudimentary exercise with walking down the halls even. Then after that, they go to a rehab facility where they exercise under supervision in a graded fashion, so that the exercise is increased as the patients tolerate the exercise, and they continue with the risk factor modification um, uh, with regard to smoking cessation, blood pressure, and cholesterol, and stress reduction. So really, cardiac rehabilitation should encompass all of this, and then enable patients to really establish good therapeutic lifestyle changes, wherein they have the ability, down the road to continue this and not to come back with weight gain and elevated cholesterol and increasing stress, et cetera, and hopefully avert a future event. So that's really the purpose. A lot of people don't think rehab is important, but the data do show that rehab seems to reduce or does reduce recurrent events and just lead to overall improved health. So it's definitely a good thing, and it's underused.
Good to know. Thank you. One more question in the chat I wanted to ask you. What role does stress play
Hmm.
with heart disease? We talked
Yeah, it's
about
funny.
meditation. So
Yeah, it's funny. We used to talk about stress a lot, and there were a couple of guys in the '60s who really started this whole stress and cardiovascular disease, discussion. Um, and things in medicine kind of go in and out of vogue, basically. So we don't
Mhm.
talk about it that much now, but stress is definitely important, and stress definitely contributes to vascular disease and to cardiovascular events. Um, uh, if you look at some of the literature practicing techniques such as Tai Chi and yoga and meditation, and there's a famous cardiologist at Harvard, Herb Benson, who wrote a book called The Relaxation Response, and which was a great tool for stress reduction and an easy tool actually for stress reduction. These things really help. They're challenging to incorporate into daily life, but once people kind of do that and incorporate it into daily life, often it becomes part of them forever. So I would encourage everyone who's had a cardiovascular event or who is heading toward potentially a cardiovascular event to look into stress reduction techniques and try to incorporate something into their lives.
Hmm. Good to know. So I have a final question here for you. And actually, there was a question in the chat about being an advocate for yourself as a patient. And it kind of plays into a question I had prepared already. And this gets back to a conversation I know you and I have had a lot. And I hear this from, doctors all over the country. In the cardiovascular space, there's been so much innovation, so many options, but it's gotten, I think, increasingly difficult for patients to get access to the medications that the doctor prescribes. So my question, I guess, for you is, what should a patient do if they are having issues getting their insurance company to pay for the medications that the doctor prescribes them? Are there any best practices or any physicians that you've worked with that you feel like get a good job getting past the prior authorizations or the non-medical switches or whatever the protocol might be?
Yeah. So as an overarching theme, I would say patients always have to be their own advocate. The healthcare system is challenging to navigate, and whether you're in an outpatient setting or an inpatient setting, I think it's always good to be aware, to have, if you can have somebody there helping you through it, and a personal advocate, a spouse or child or friend or whatever, that's valuable, very, very valuable. Be as knowledgeable as you can be. I'm not saying look for Dr. Google, but I'm saying understand what's going on to the best of your ability. Find a clinician who you trust, and then trust that clinician. So that's pretty much the way I think it works best. With regard to medication access, it is very, very challenging, and there are a lot of struggles that we have. I would say, remember that the patient has the loudest voice. Use it. If you're being denied a medicine that your doctor wants you to have, call your insurance commissioner for your state. They will be active. They will listen. Speak to the doctor a lot. Call your insurance company. Say that you're entitled to the medicine. You want the medicine. If it's just the doctor's office doing it, you're not going to get as far as if you also engage in the conversation.
That's great. Thank you, Dr. Baum. Well, I think that pretty much wraps all the questions that we have for you. It's always a pleasure to talk to you. We really appreciate your time. We know you're a busy man. So thank you so
Well,
much
thanks,
for being here with us tonight. And we'll be speaking soon, I'm sure, working on a number of different things together. So thank
nice
you.
speaking to you. Take care.
All right. Take care.
Bye-bye.
So with that, I want to invite my colleague, Jasmine Patel, to the screen, and Jasmine will be interviewing our two heart patients for the evening. Jasmine, thank you.
Thanks, Ryan. I love hearing from Dr. Seth Baum. He just breaks things down in such a simple way, and it really makes things easy to understand. So thank you so much. Hello, everyone. My name is Jasmine Patel. I am Patch's Director of Policy and Outreach. Joining me today are Annie DeVelasco and Ken Karlson. Ken is a volunteer advocate with Mended Hearts, and Annie is a Women Heart champion. Mended Heart and Women Heart are two amazing nonprofit organizations who work to improve the quality of life for people living with or at risk for heart disease. Much of their focus is on education, advocacy, and peer-to-peer support. We are very grateful to continually partner with both organizations in our awareness activities. So I'd like to bring on Annie and Ken. Welcome, both of you, and thank you so much for joining us. It's very important for people to hear from those navigating through their heart disease journey. And Dr. Baum, as I said earlier, he gave us a great overview, but as you know, as advocates, there's a lot to learn from the lived experience. And really, you each have your own unique stories that will be valuable to the people watching this webinar today. So first, let's learn about you before we get into your specific stories. Tell us about yourselves, where you're from, what you do for a living, and especially what you do for fun. So Annie, if you will please go ahead first, you can answer that first set of questions.
Hi, good evening, everybody. Hi, I'm here in Coral Gables, Florida, which is a beautiful suburb of Miami, Florida. And we are having a lovely sunny day, but somehow I'm still jealous of all of you who have that beautiful early fall. I know that doesn't sound right to those of you who have in cold temperatures. Anyway, actually, I'm a registered nurse and I've loved working in healthcare all my life. Luckily, I just retired, so that is good news for me. I am very happy to report that I'm busy all the time. And for those who know me, when you talked about having fun, I think most people know that I'm really in tune with doing that. So I have a lot of fun. I have wonderful friends, and I keep really busy volunteering and doing fun things with my friends and family. And I have 2 grandchildren, ages 10 and 12, here locally. So as you can imagine, that really takes a big part of my time and makes me happy.
Thank you, Annie, and congratulations on your retirement. Very exciting.
Thank you.
Ken, what about you?
Okay, my name is Ken Karlson. I'm originally from western part of New York State. I grew up in a small town, went to college in New York, and ultimately got a job in New York City in finance. And after a few years, met my wife, Elisa, who's from Brooklyn, and we settled down just for a few years, we thought maybe in New Jersey. Turned out to be 30 years later, and after the kids were out of the house, we kind of looked at each other and said, what are we doing here? Let's go to Florida, and which was also triggered in part by my heart attack. There were a whole lot of changes that came very quickly after the surprise heart attack, not the least of which was deciding to sell the house in New Jersey and move to Florida. So now we split our time between Florida and Utah. We're kind of reverse snowbirds. We go to Utah for the ski season in the wintertime when it's snowy and cold, and we come back to Florida when it's warm and sticky and rainy. But that's pretty much it. We'll probably get into more of the details as the Q&A goes on.
Thanks, Ken. Yeah, exactly. I mean, actually, this dovetails great to my next question. So you said it already, you've experienced an unexpected heart attack, and everybody watching should know that both Annie and Ken survived unexpected heart attacks years ago, and they really have come a long way mentally, physically, emotionally. So Ken, I'll start off with you. Can you just give us the rundown of the day you experienced your heart attack?
It's interesting because in retrospect, it wasn't just a day. It was perhaps up to 6 months and certainly at least a week of different things that were happening, all of which could have been angina or heart attack or both. So at the time, as I said, I was living in New Jersey, and always thought I was healthy and fairly athletic, snow skier. At the time I was running and swimming and playing golf and doing everything I could to stay in shape for ski season. And everything, seemed to be fine. The August before, I had my annual physical with my primary care physician, who said, well, your cholesterol is a little high, your blood pressure is a little bit high, but nothing really to worry about. Just keep an eye on it. And if anything changes, maybe we'll consider putting you on some medication. But she didn't see any need for any medication. That was in August. And in January, I had my heart attack. What happened was I was going to the gym during my normal routine. I would go to the gym maybe 3 days a week. And the first thing I would do is get on the treadmill and do about a 30-minute run. So I got on the treadmill one day and I just couldn't even get started. As soon as I started jogging just a little bit, I got very, very tired, exhausted. And I felt this strange sensation in my lungs like I had bronchitis. So I would sit down and rest for a couple of minutes and then I'd try it again. and the bronchitis feeling would come back, and I had no energy, just absolutely exhausted. So I went home, took a day off, normal routine, and then tried it again. Same thing, just could not get through anything, and I had this bronchitis feeling in my chest. I don't, if you have bronchitis and you walk outside in a cold temperature like it was in January when this happened, you take a deep breath of that cold air and you feel this sensation in your lungs. And that's exactly what I was feeling, bronchitis. And after doing that a couple of days, I said, well, the least I can do is walk the dogs, because they need, some little exercise too. So I tried to walk the dogs, and I had to go up the hill to get started on the walk, and I couldn't even make that. I'd come back home and lay down for 5 minutes. So this is strange. So the next night I said, I'm going to make this dog walk thing happen. I'm going to press through it. So we did that. It was probably about 2/3 of a mile in that range, walking the dogs, and pressing through this sensation. And when I get back to the house, I'm feeling weird or whatever, but my wife was on the Peloton, and I said, tell you what, I'm going to go to the gym. And I don't go to the gym. I'm going to go to the grocery store, get something for dinner. I'll be back by the time you're off the, Peloton. Dinner will be ready. She said, great. So I go to the grocery store, feeling more and more weird. And I'm in there. It's, like I said, January, right? And I had my coat on, and I'm in the grocery store going through the aisles. I break out into a cold sweat. My hands are sweating, cold sweat, strange bronchitis feeling. And I said, darn it, I got to go to the walk-in clinic to get something for this bronchitis, because this is really getting to be annoying. So I went drove myself to the walk-in clinic, 20 minutes to 8, because I closed at 8 o'clock, and I know I was cutting it close. And I said, what's you in for? And I said, I think I got bronchitis. So they listened to my lungs. They didn't hear anything. They took my blood pressure. I've never seen a tech just turn on their heel and walk out of the room for no apparent reason. And then he came back in and he said, you had very, very high, extremely high blood pressure. We have to do an EKG right now. The doctor wants to see an EKG. So we do the EKG, gets the results, turns on his heels, walks out again. Now the doctor comes in and says, what you been doing? And I told her, and she said, how did you get here? I said, I drove myself here because I want to have something for this bronchitis. And she said, you don't have bronchitis. There's something probably very bad going on with your heart, and you need to go to the nearest emergency room. And I said, I don't think so, but whatever. So she listened to my, lungs again, and she said, you do not have bronchitis. You have two choices. You can go in an ambulance to the nearest emergency room, or a friend or family can drive you there. But those are your only two choices. So I said, oh, come on. All right. So I called my wife. I didn't want to spend the money on an ambulance. So I called my wife. She got her off the Peloton. She drove over to the clinic and drove me in. They walked me, when I handed those results into the front desk of the ER, they whisked me in, put me in, got pipes and tubes coming out, blood tests going on. Just a few minutes later, they confirmed I had a heart attack, which I still didn't believe. There was no like elephant sitting on my chest. There's no pain running down the arm. There was no, I didn't fall over on the floor or whatever. Just had these very, very weird sensations and total inability to do anything athletic. So I made the mistake of going to the nearest emergency room as opposed to the nearest cardiac center, which was only about 10 miles away further. And I should have gone there, because while they were able to diagnose this, I did a diagnostic cath, and they saw the blockage and they showed it to me, but they couldn't do the stent procedure because they didn't have the emergency room surgery suite, whatever it would be, in case they had to crack me open. So I had to cool my heels there, spend the night, and then they took me over to Morristown Memorial, where they could do the stent work. And that was my day.
Wow. It's a series of events. So you did get a stent placed in.
Yeah, I got one stent in my LID, the Widowmaker, and obviously medications, and we can talk about all the other things I've been doing. But just to put in perspective, you guys were talking about the LDL.
Yes.
When I had my visit with my primary care physician that August, she said, "Well, your LDL is a bit high, but that's really okay because your HDL is also high. So you have a high total cholesterol, but it's all likelihood the HDL, sort of makes up for the high LDL. My LDL was 160. Now it's 54. So I wish I had known more about it. I didn't know 160 from 1,000. They could send any number they could have told me. I didn't know if it was good or bad. But there was also a family history I was not aware of at the time. And they said, in retrospect, if they'd known about my family history, they would have had me on they would have had me on some medication to treat cholesterol and blood pressure.
Does the LDL, does it run down to your children as well? Do they have high cholesterol?
Well, that's a note I made from the doctor today when he said that kids should have been tested when they were 2.
Yeah.
I didn't have my heart attack until they were much older, but now my 30-year-old daughter and my 26-year-old son they don't know yet, but they're going to go in and have a blood test.
Yep. It could be familial hypercholesterolemia, which is where you're born with high cholesterol and it basically builds up in your arteries until you start treating it. So, anyways, I'm glad that
doctor, says that if we can keep it under 60, he says we can actually begin reversing it. So
Yep. That's great.
That's my new plan, and I'm sticking to it.
Good. Well, thanks for sharing that. And Annie, I want to jump to you now. Actually, Dr. Baum talked about this briefly. He talked about stress and how that impacts heart disease. And we all are human beings. We deal with different kinds of stress, work, finances, family, you name it. And of course, currently, because of COVID, we have another huge stressor we're all trying to navigate. And I think a lot of people really underestimate the dangers of very high stress and really the importance of finding ways to manage our body's response to stress. And I say all this because, when we first spoke, you said a stressful event was a cause of your heart attack. So can you just dive into that day and share what exactly happened?
Yeah. I kind of hate to go back to that day, but I revisit it fairly often. It's okay. It's therapeutic. But in June of 2020, I was at work, and all of a sudden I received some very frightening and stressful news about the health of a beloved family member. Well, as soon as I read the report and realized that something could be seriously wrong with one of my kids, the strangest things began to happen. I began to feel some pressure in my chest. I started to sweat. Being a nurse, I reached over and took my pulse, which was irregular and racing, and I felt very ill all of a sudden. So I went and sat down, and the next thing I know, my boss walks by, and I guess I didn't look too well, and he said, "What's going on?" And I told him what happened, how I felt. So he basically threw me in a wheelchair and rolled me over to the emergency room, which was right there, thank goodness. And I got to the emergency room, and all of a sudden they're taking EKGs, taking my blood pressure, drawing blood, and basically surrounding me. And the next thing I know, they said, "Well, we're going to take you for a cardiac cath." And I said, "What are you talking about?" It scared me to death because I had no idea what was happening. And my mother, who had died at 42 years old of heart disease, had actually had a cardiac arrest in the cardiac cath. So I wasn't too thrilled about having to go for a cardiac cath. But anyway, I went to the cath. I had the cardiac cath. I came out of the cath, and they did no intervention. I had no stent. I didn't need bypass. So I said, "Oh, good. So when can I go home?" And that's when they said, "You're not going home. You're having a heart attack." Well, honestly, that news almost gave me another one. So it was very surprising to me. Here I was, and what I thought I was relatively young. This was 20 years ago. And the next thing I know, I'm in ICU, and then I'm in the cardiac care unit. And basically in those days, I was in the hospital for 5 days. And it was a whole new world for me. I just didn't know who I was, what was happening. It really was a major life event that I was totally unprepared for. And that's basically my story.
Wow. Very crazy. Thank you for sharing that. And there's a question that just came in from the audience. And again, it just relates very well to my next question. The American Heart Association, they say that 1 in 5 people who have had a heart attack will be readmitted to the hospital for a second one within 5 years. These are statistics for the people that are watching, and you don't have to become a There are steps you can take to mitigate your risk. So Annie, I'll start with you. What would you say was the most important step you needed to take to prevent another heart attack from occurring?
Well, first of all, I'm celebrating 21 years, so I feel very fortunate. Um, I think that the thing that truly made the most impact on me right away, besides family support, was actually going to cardiac rehab. You know, it truly changed my life because a lot of people don't talk about the actual fear and the worry that you're not the same person anymore that overcomes you in the beginning. And everyone tells you, okay, the doctor sent me home basically with no instructions except do some exercise, take these new meds, watch what you eat, and avoid stress. Well, avoiding stress is pretty impossible nowadays. So there I was at home, not knowing what to do, frightened in a totally different world. And a dear friend of mine told me about cardiac rehab at our local hospital. When I called, I spoke to Susan, the manager, who was so empathetic and understanding with me, took me through the steps to apply. And shortly thereafter, I started cardiac rehab. It was a different experience because in those days, there was only one other woman. And most of the people were a lot older than me. But I immediately began to do all the things that Dr. Baum talked about, continuing to learn about diet management, exercise, stress management, all the other risk factors that you really need to have reinforced when you're first diagnosed. So cardiac rehab was wonderful. I made lots of friends. I didn't feel alone. And the thing is that cardiac rehab helps you not to be afraid, because when you realize you can all of a sudden walk on a treadmill where you thought you maybe could never do anything ever again, and you walk on a treadmill and they monitor you and you get off and they say, wow, look at your EKG, you did great. And today you did 10 minutes and tomorrow you did 15. And by the time you're done, you're doing 30 minutes and much faster and lifting weights and all that. You prove to yourself that you have what it takes to get better. And I think that's better than anything anybody can tell you, just your own personal satisfaction. And it also motivates you to continue the same lifestyle, which I've tried to do the rest of those 20 years. So I would say the most important thing was, for me, life-changing was cardiac rehab. And they even asked me to work there. So I did. And I worked as a cardiac rehab nurse for a very long time before my retirement. Between that and my cardiologist and the team that I have around me, that has truly made heart disease something that I'd love to advocate for, but nothing that you have to have a horrible life because it happens to you.
Wow, what a positive turn of events. Thank you for sharing that. Ken, what about you? What was the most important part of your post-heart attack journey?
Right. Well, the biggest thing for me was the shock and surprise and, disbelief that it could happen. Why did it happen? How do we keep it from happening again? What can we possibly do to make sure that something like this never happens again? I thought I was in good shape. I thought I had a reasonably healthy diet, and clearly I didn't. The one thing that I was not aware of, I knew my uncle died of a stroke and had high blood pressure, but I never got the correlation, between him being, my uncle and possibly having something to do, with me genetically. But that's probably it. So we did a lot of reading, my wife and I, on, what can you do? We learned about cholesterol, blood pressure, diet, exercise, and kind of broke it down into two different categories. What factors are controllable and what factors are completely out of our control. And the ones that are completely out of my control anyway would be my gender, my age, and my family history. And maybe stress, maybe not stress. We could talk about whether or not stress is controllable. I decided to put stress in the controllable pile, along with diet, exercise, lifestyle. Diet, exercise, lifestyle, of course, medication following the doctor's orders. So we just researched what we could do about it, because if we can figure out what levers we can pull and what we can do about it, and we choose to ignore the things that we have no control over, that helps relieve the stress, because you have to ignore the non-controllables because you can't do anything about them anywhere. All you can do is worry about it, and that's just going to get you stressed, and that's not helpful. So I lost 20 pounds, I got all my charts here. I can go way back to before and after in terms of HDL, LDL, triglycerides, non-HDL, all the different ones. And those are control levers. The diet, the exercise. Now I'm doing cardio more so than I was doing. A lot more weight training as well. I got away from that and started focus more on the cardio because I want to lose weight, not build up weight. So those are the things that we've been working on. And again, for me, it was just identifying what it is we can do about it and control the controllables, and then just have a good life after that.
So there's a question that came in. I was going to ask it later, but I'll ask it now. So there's a question: tips or best practices for remaining positive. I mean, Annie, you talked about it. You obviously had a community of support behind you, but is there anything in specific, something you were just telling yourself when things seem tough? And I'm asking you, Annie, and you can as well. Anything in specific you can highlight?
Well, specifically, I'm an optimist to begin with, and the fact that I'm a survivor is something I remember all the time, and that reinforces it. I have so many reasons to live for my own self and for my family, and I can't talk enough about the advantages and the importance of support. So through my organization, we support women with heart disease, and I've been doing it since 2003. And we meet every month. And I think that support and reinforcement, letting people tell their story, learning from one another, all of those things contribute to my positive attitude. It's good for me, but it's also good for me to pay it forward. Every time I talk to somebody with heart disease that's in that frightened space where I was, it gives me a better reason for living and improves my attitude and makes me live with my heart disease and let that be a part of my life that has turned into something really good.
I love that. Ken, what about you?
Well, again, if how to manage stress or anxiety or what have you about it. Again, for me, it's ignoring the things that you have no control over, just getting them out of your mind and forgetting about them and focusing on the things that you can do something about, and put a full court press effort on those things and ignore the rest. And I found out early on that I would tell my story to all my friends and relatives, this whole kind of thing we're doing right now, and they were glazing over after a while. So joining Mended Hearts and having the opportunity to visit with patients in the hospital or out of the hospital who are going through the same thing, I get the cathartic effect of being able to tell my story, help them hear their story. And what sort of motivates me is I was so unknowledgeable before my incident that if I can help just one person become more knowledgeable about their situation and what they can do about it, and if there's anything that I've gone through that I can help them with that saves their life or makes their life better, or they don't have that second heart attack, that gives me a big lift, a big boost. Because if what I went through and how I've handled it can help just one other person not have happen what happened to me or worse, that's a good motivation.
Yeah, it's great to hear how you're just paying it forward with the organizations you volunteer with, Women Heart and Mended Heart. And I just want to encourage anyone who is watching this, if you're interested in joining them, they are amazing organizations. You will find a very positive community to support you, and really you will become better at advocating for yourself and on behalf of others living with heart disease. So I just wanted to plug in. Yeah. Yes, and you both are representing your organizations very well. Okay, well, we have one more minute, and I want to ask this question because it's very important. Talk to us very quickly about your relationship with your cardiologist. Shared decision-making is extremely important when it comes to just navigating through somebody's heart health. So tell me how your relationship with your cardiologist is great. What are the great aspects about it? Annie, and then I'll end with you, Ken.
Okay, I'm happy to talk about my cardiologist, Alvaro Gomez, here in Miami, who's a cardiologist and an interventionalist. Dr. Gomez and I are a real good team. He listens well. He's pretty straightforward about things I need to do and how I'm improving. We shoot for the numbers to be good together. I can ask him anything. He's very interested in helping others. He volunteers every year to talk with our support group. He does everything he can in the community. So I have a great relationship with my cardiologist. I have a lot of faith in him. I also work with him and my primary together. So we have a generally well-coordinated approach. And I feel very comfortable and confident. So that is a good thing to know, especially after something as big as a heart attack. But yeah, it's a very important thing to have a good relationship with your cardiologist. And I do.
Thank you for that insight. Ken, I'll end with you.
Sure. Well, to be honest, and no offense whatsoever to the profession, but I don't see a cardiologist anymore.
Okay.
After my incident, I saw a lot of cardiologists, and I really took a deep dive and really did a lot of research and made a lot of life changes. And over the course of time with 2 different cardiologists in New Jersey over time and coming down to Florida and transferring down here, I didn't have a primary care physician. I didn't go to any other doctor whatsoever. I didn't want to go to the primary care physician I had didn't diagnose my problem. And within, just a few months after my annual visit, I had a heart attack. So at that time, I was not enamored with, primary care physicians, and I wanted only to deal with cardiologists until I got this thing under control. And for better or for worse, I think we got it under control. And now, instead of going to the cardiologist only, we have a concierge primary care physician arrangement where we pay extra and we get extra services and testing and regular office visits and same day, office appointments and that sort of thing. So we're focusing on now more of a kind of a holistic approach, and he focuses on a wide range of things, not just the heart related things, but he is focusing actually more intensely on. He's the one that came up with the idea of trying to get my LDL down below 60 in order to reverse the heart disease, as opposed to managing it under 70 to manage it. So I'm liking it so far. If things were to take any sort of turn, I would immediately go back to a cardiologist. But for now, the concierge service is working nicely for me.
Yeah, finding a clinician who works for you and is doing the right things to manage your risk, that's the most important thing. And on that note, I just want to thank you both for joining. This was very interesting and also very, very positive. So those of you who are watching, if you do want to get in touch with Annie and Ken, please reach out to our organization. We can connect you with them. If you're interested in joining Mended Hearts and Women Heart, please reach out to them as well. You can reach out to us and we can connect you, or you can directly visit their website. So thank you again, Annie and Ken. Really appreciate your time.
You're welcome.
You're welcome.
In addition to thanking Annie and Ken, I want to thank my colleague Ryan and Dr. Seth Baum. You were amazing. As Ryan said earlier, Patch's mission is about helping people. If you are aligned with our mission and our clinician, patient advocacy organization, or individual living with heart disease, interested in sharing your story with the goal of impacting health policy, we invite you to join us. Our membership is free, and we always welcome collaboration. On this slide are all the ways you can contact us. Thank you to everyone who tuned in this evening. We will see you again soon. Be well.